All right, everyone. It's really nice to see you all. I am kind of in awe of all the work and compassion and love that you share with the children that you help take care of. My name's Emily. I use she, her pronouns. I am a developmental and behavioral pediatrician. I did my training all over the country, but I completed my fellowship here. I can't even remember how. It's been over 10 years since I finished my fellowship. And I've been working at the Institute on Human Development and Disabilities at the University of Washington this whole time. I actually started um, as a volunteer in undergrad working at the Institute on Human Development and Disability, and I volunteered for the FAS clinic way back when I was like, I don't know, 19. So I've spent half my life in this space in one way or another, and I feel wonderfully connected in that way. And so I'm just really grateful to be here. I prefer Emily rather than Dr. Myers. When I'm in trouble in clinic, I'm called Dr. Myers, which doesn't, it's kind of like being called your full name by your parent, like, oh, what's happening? What did I do? So you can just call me Emily, um, and we'll just get started. I'm going to share my screen. And where's the share button? I found it. And here we go. And I'm going to go up to, can y'all see my starting slide with the picture, the really lovely picture of the brick building? Can you see it, Lisa?
Yeah, sure can. So
Okay.
Amy was asking about a passcode. Um, Amy, are you in the group? Because if you're here, then are you wondering about because you're muted. Well, why don't we wait?
I'm on it on my phone, but I was trying to watch it on my tablet because it's a bigger screen and all of that wonderful things. But if there's no passcode, then I'll just stay on my phone and you guys will just
Okay.
have to be small.
Yeah, thank you. Yeah, I don't know of a passcode. There
Let
should.
me let me see if I had one in the email I got from Luann.
Okay, yeah, because she didn't give me a passcode, so thank you, Emily.
Yeah. Oh, okay. She just nope.
Okay. Well, I'll just deal with it then.
Oh, I'm sorry.
It's all right. No big deal.
I'm gonna say everything out loud because not everybody accesses visual information, and most of the stuff that I have are just big pictures anyway, with not a lot of words on the slides because I have dyslexia. I identify as having dyslexia, and I hate reading. Made med school like super easy for me.
Mhm.
Um, but I survived. All right, let me go back to sharing my screen. Okay, can everybody see it? I got a thumbs up from folks. Cool. Thanks, Lisa, for monitoring the chat. Okay, so the Institute on Human Development and Disabilities is behind the University of Washington Medical Center, Montlake. This is the beautiful building. It was built in the 60s. Can you tell? It's brick with concrete awnings. I haven't seen concrete awnings being actually made in a very long time. So it's very brutalistic. Um, President Kennedy and his family were very interested in supporting people with developmental disabilities. And so, through the legislation during that time, instituted or legislated funds to be distributed to universities across the country to build centers for human development and disability. And they've been called a variety of things over the years. It's now called an institute. It's no longer a center, but it still says center on this slide. It doesn't really mean anything, but this is where we physically are. Um, right on the water. It's kind of a beautiful, beautiful space to be. Um, and it's where we do a lot of our work. Hello. So I always like to lead off with a few objectives. So I'd like to describe for you all, in case you're curious, what developmental monitoring means for drug-exposed infants, or also children who are at higher risk of having developmental differences. So we'll start with that and what we do in the program. There might be some folks who have been through our program on this call. And then we'll talk about what we know, what I know. And I say collective we because I did a literature search. I didn't do the primary research looking at this, but what I know and we know around prenatal drug exposure and what we expect a child's development to be like. And then we'll talk about some support resources, which many of you probably already know and are part of that system. And then we'll spend some time answering questions. So what I hope you get out of this is that there's a lot we know, there's a lot we don't know, and what's right in front of you is really the most important thing, the person who is right in front of you. So let's get going. So we're going to start by describing our program at the Institute. These are the folks who are involved in the leadership of these programs. We have Dr. Kathleen Lehman. She is a clinical psychologist, and she's the director of the clinical training unit that houses these clinics. I'm the medical director. Dr. Kendall German is a neonatologist, so she works with all those babies in the NICU. And she also sees patients out in our clinic with us, and she's always feels like a fish out of water when she's seeing a 3-year-old in clinic because she's used to seeing all the little teeny tiny babies in the ICU, but she does a really great job with our older kids too. And she's really interested in maximizing the potential of kids who have experiences in the NICU with their babies. And then Dr. Sunny Jewell, who's also a neonatologist, and she's the director of that whole brick building, the Institute of Human Development and Disabilities. So what we know now about developmental monitoring is that children are not just drug exposed infants, but infants with really complex medical prenatal experiences and early neonatal experiences are surviving. So babies who are born premature, we're able to resuscitate and keep babies who are earlier and earlier at birth born. So 23, 22 weeks gestation out of 40. We have the technology to keep these babies alive and survive and leave the hospital. Lots of children with congenital birth defects. We have all of these interventions that we can do. And so now that we've sort of figured out the surviving part, we have to start thinking about the now what part. Like you leave the hospital and then what? You can't just pat ourselves on the back that we've kept little people alive. Now we have to say, how do we help them thrive in their communities, with their families, with their caregivers, all of those kinds of things. And so developmental monitoring is really where research is moving towards. So we're looking at what interventions do we do in the infant period to maximize developmental outcomes moving into early childhood and adulthood. And so hospitals and researchers are really interested in trying to figure out ways that we can improve or maximize potential, whatever that potential may be, and looking at it from a variety of different lenses. And so in our developmental monitoring clinics, we often have a whole bunch of different groups of people who work together to study, to promote outcomes, to help take care of patients. It's really a pretty vibrant and interdisciplinary place. At the IHDD, we have 2 major developmental monitoring clinics. We have our general neonatal developmental monitoring clinics. Those are NICU clinics, and that clinic follows children with a variety of prenatal and neonatal conditions that include prematurity, brain injury or infection, prenatal drug exposure, some other birth defects, and other issues. And then we also have a developmental monitoring clinic for children with congenital heart disease who have had open heart surgery when they were less than a year old. So we see these two large patient populations. Most of them come through and are born at the University of Washington Medical Center or cared for in the Seattle Children's NICU at this time, but we're working to expand to a larger catchment area and more NICUs. And this is more detail. We have sort of a faster track evaluation clinic where they're just seen by one provider, and then we have what we call a sort of full meal deal. And we follow kids in LAMS, which is the late and moderate preterm babies clinic, and the infant development follow-up clinic. And depending on what the early neonatal experiences are for children, they either go into the LAMS clinic or the infant development follow-up clinic. And the cadence for who sees them and how frequently is a little bit different because it really depends on what their early infant experience is. In the LAMS clinic, we see, those are kids that we see who have prenatal substance exposure, which is what you're mainly here to hear about. We see children starting at age 3 months, and then we see them at 9 months, and then 18 months, and then 24 months. And then in the infant development follow-up clinic, we follow kids at that same cadence, but all the way up through 5 to 7 years. In the LAMS clinic, children in the infancy period are seen by a developmentally focused pediatric provider, so a pediatrician who performs a formal medical assessment, including a validated neurological assessment to look at the infant's neuromotor skills. And they also at 9 months get a hearing screen. In the infant development follow-up clinic, children will see therapists or psychologists and pediatric providers. It's sort of a like full platter of specialists that see them all on the same day. And so and they get a little bit more closer monitoring in early childhood because they're at much higher risk than for cerebral palsy, which is something that the kids who go through LAMS are at much lower risk for. So Seattle Children's is one of our partners in this whole project. We have a very large NICU and a very large medically complex patient population that moves from discharge at Seattle Children's NICU to our institute. And so we really are working as collaborative partners in promoting the health of children who have these lived experiences. The UW, University of Washington Medical Center, also provides a substantial support, and our clinics are housed at the at University of Washington. But we're really sort of all trying to work together in this area. Our job in these clinics is to provide comprehensive evaluations and longitudinal surveillance of development for children who've had a rough start in the beginning, that have needed NICU care or have had prenatal drug exposure or other medical outcomes that put them at higher risk of having developmental problems. So we look long-term at their development, and we support and help triage therapeutic recommendations for children over time. We also spend quite a bit of time in education. So we have medical students, residents, subspecialty fellows, nurse practitioner students, many different kinds of many different healthcare providers. In addition to that, we have speech therapy trainees, psychology trainees, audiology trainees, all coming through to participate in the care of these children and to learn. Okay. Now here's why y'all came, right? To discuss and review what we know and what we don't know about developmental outcomes associated with prenatal drug exposure. And when I think about drugs, there are drugs that we prescribe that can adversely impact children's development. Certain anti-seizure medications, when taken by gestational parents can cause developmental differences. So I think the ones that folks are most interested in understanding a little bit more, and alcohol is, of course, one that has been discussed and has been reviewed in detail. Ones that I'm going to focus on today are opiates, because we're seeing more and more children who are exposed to opiates. That includes methadone and also the treatment medications like buprenorphine. We'll talk about marijuana, because that is something that often some gestational parents use for nausea treatment during pregnancy. We'll talk about stimulant medications for treatment of ADHD and also illicitly. And then we'll also talk about antidepressants like selective serotonin reuptake inhibitors. So gestational parents often will have questions about these, and also foster caregivers will have questions about these as well, because we often see these in our charts of our patients that we're taking care of. Studying so I went back to look at the literature, and I was reminded about how difficult it is to really study these different kinds of prenatal exposures with any degree of quality. You know, we don't do randomized control trials with gestational parents giving meds to some and not to others, because that's unethical, right? And that's really the best way to learn if something causes something else. And that's an unethical approach to understanding these kinds of relationships. So all of the studies that I'm going to go through are what we call observational studies, which are looking at patient populations and trying to compare them to one another and trying to compare them to what we already know. And every study has its own patient population that they studied, which may or may not be relevant to the child that's sitting right in front of you that you're caring for. So oftentimes studies are not taking into consideration that the population that they're studying is actually really different than a nationally representative group of people. So it's not applicable to everyone, but the way the results are shared makes you feel like, oh man, this is true for all patients. And so when I show you the studies, I picked what I thought were the best studies to look at and help us understand developmental outcomes in the patients that we're talking about. But I'm also going to point out the flaws in these studies so that you don't leave this talk thinking, oh my gosh, this is completely applicable to the child who's right in front of me, because it's really difficult and it's not straightforward. Welcome to child development, right? We can't ever predict what's going to happen next. I don't know if anyone else has that feeling. I'm surprised every day when I wake up in the morning and look at my kid. I'm like, you surprise me every day. And I do this for a living. Okay. Oops. I have up here, if you can use your smartphone, this is my interactive portion of the talk. I would love for you all to think about and tell me, fill out this question. So which factors do you think impact a child's developmental outcomes? If you can scan the QR code with your phone, it's anonymous. No one's going to know what you've said, and pick the things that these factors below that you think impact a child's developmental outcome. And we'll see what people say. And it's totally okay if you don't feel like doing it, but I would love it if folks want to take a gander at which of these factors do you think impact a child's developmental outcome. We have indeed. I have to move you. I'm moving you around. Yep. Bonnie, all of them. Anybody else? Yeah, I think all of them. And so when we're looking at a child's developmental outcome, or I'm in clinic and I see a patient who's of the things that make them who they are, one of the 12, 13, 14 factors is that they had some sort of prenatal drug exposure. And this child has a developmental difference. Can I say with 100% certainty that their developmental difference is because of their prenatal substance exposure? I am never going to be able to say yes, because all of the things that children experience that are in and out of anyone's control, right? Some are in our control and some are not, are going to impact a child's developmental outcome. And it could be positively or negatively, right? We've got strength-based things like family, caregiver, community support. We have lots of things that can impact a child's development, both positively and negatively. And one of them happens to be prenatal drug exposure. Ellie, I like that little forehead on the top of your, what a good little person there. A cherubic face. Okay, I'm going to go on to my next slide now. Okay, so we're going to talk a little bit about
She's talking about him.
it's
What? Sorry, I put it.
okay.
I,
It's okay.
I'm trying to work the little tiny cell phone I've got handy here.
So we're first going to talk a little bit about prenatal opioid exposure. And there are a couple of studies looking at that I think are really the best studies to look at. And I would encourage you, if you want to look them up. Both of them were from the American Academy of Pediatrics. One looked at, both of which looked, the prenatal opioid exposure, neurodevelopmental consequences and future research priorities is generally a review article, but talks about and puts together all of the different studies looking at prenatal opiate exposure. And then the best sort of biggest study looking at the largest group of patients is the one that looked at neonatal head circumference in newborns who had neonatal abstinence syndrome. And so what these two studies, excuse me, showed was looking at the head circumference study, children born exposed to opiates had slightly smaller head circumference, but is statistically significant compared to children who were not exposed to opiates. One of the things that I had a problem with this study was that the children also who were born prenatally opiate exposed were significantly smaller in size in general than in children who were not opiate exposed. And so the question is it hitting the brain more than the rest of the body? It's unclear. And they also had difficulties with separating race and ethnicity. So we couldn't determine, there were other socio-demographic factors that were associated. So there was, between the opiate and non-exposed opiate patient populations, the non-opiate exposed populations had gestational parents with a higher degree of education, more private health insurance, and the opiate exposed had those other demographic factors. And so when we think about all of the soup that is developmental outcome, we have some big differences between the patient populations that they studied. Prenatal opioid exposure, there have been smaller studies, most of which were not nationally representative, but were reviewed in this prenatal opioid study that talked about increases in challenges with executive functioning and learning. I personally don't find any of that research alone compelling enough to say that this is something that we should expect for all patients who are exposed to opiates, because as I said, the impact on a child's development is so multifactorial. But these two papers, and I'll save this as a PDF and you can look them up if you would like, you can get them off the American Academy of Pediatrics website, can provide you with more information and general future directions. I think the more research we have looking at patient populations and trying to do a better and better job of understanding the root difficulties and the factors that impact a child's development, the better. Marijuana is another really commonly used drug and medication in our area of the country. There's a couple of studies that I thought were pretty big and pretty good looking at patient populations and outcomes associated with prenatal cannabis exposure. There is some evidence that children with prenatal marijuana exposure can have signs and symptoms of attention deficit hyperactivity disorder. And yet on the flip side, the Journal of Developmental and Behavioral Pediatrics came out with a study in 2025 saying that there is no association between prenatal cannabis and ADHD. So we have big studies that often conflict with one another, and which do we take as ground truth? We take neither, basically, because as we know, what impacts a child's development is so multifactorial that taking one factor in isolation is really just not the best way to think about the person in front of you. There are lots of people take stimulant medication for treatment of ADHD. And studies have looked at stimulant use in children, stimulant exposure. Prescription stimulant exposure has not been shown to be associated with any developmental consequences. There have been some concerns about placental blood flow with the use of stimulants. And so when gestational parents are pregnant and using stimulants for treatment of ADHD, or there is known use of stimulant, whether illicit or prescribed, they monitor growth of fetuses very closely. Looking at development and behavioral consequences of prenatal methamphetamine exposure, it's very complicated and mixed. This paper was done in 2015, which is a really quite some time ago. And I think I see methamphetamine use less frequently than I did 10 years ago. I see more opiate use than I do methamphetamine use at this point, or I see mixed picture of folks who gestational parents using multiple substances, including opiates and methamphetamines. But the data is not conclusive around the developmental effects of these exposures. Yeah, Karen, good question. They are even harder. They're even harder to measure. I'm sure that there are. I think you can take all of these and sort of put them together. I would say that maybe I'll get back to that once I round this all up. But
Yeah, I was gonna say, let's hold our questions to the end if we can, just because this is being recorded. And so once the PowerPoint is done and the recording stops, that'll be a great time for questions and answers.
yeah, but I will get to the complexity of that question. It's a hard one. Okay, the one that I am most curious about is, and that families often that I see, and this isn't antidepressants like SSRIs, prenatal SSRI use is not an indication to come and see me in developmental monitoring clinic. SSRIs are standard of care for treatment of depression and anxiety, and many, many people are on them, and they are very, very helpful. And so I wanted to take a look at, and I've had countless parents ask me when I see them, is this because I took this SSRI medication or something? Why did my light turn off? Did you see that? Hold on one second. I'm going to turn my light on. Sorry about that. So I did a little bit of a deep dive, and what I thought was really interesting about SSRIs in general, and what makes them actually different than any other psychoactive medication, right? They impact the brain, they are systemically absorbed. We don't see the same kinds of developmental challenges that we can see with other substances that in prenatal antidepressant exposure. However, with one exception, children exposed, prenatally exposed to SSRIs in toddlerhood tend to have slightly more motor immaturities compared to children not exposed to prenatal antidepressant use. Take that as you might think. Motor immaturities are not typically something that I get very excited or concerned about, and tend to not impact long-term developmental trajectory. But I thought it was interesting, and something that I just keep in my brain that, lots of us take SSRIs, lots of gestational parents take SSRIs, and there is no, just because your OB says it's benign doesn't necessarily mean it is, but it doesn't mean you shouldn't take it if it's good for your health. But so I just wanted to share that as well. Okay, I yammered on quite a bit about how I feel about the evidence around these types of excluding prenatal alcohol exposure. So I want to sort of gauge your feelings on, if you exclude prenatal alcohol exposure, where there's been lots of studies looking at that, do you agree or disagree with the following statement? There is clear evidence that prenatal exposure to opiates, marijuana, stimulants, or antidepressant causes significant developmental problems. And you've got like absolutely 100% agree, and then to all the way to the bottom, I totally don't agree. I say it's kind of interesting. We've got some mixed, like the most popular is that you generally agree that there's evidence, but there's some people who are like, I'm not so sure. There's a like nice spread of opinions, which I think the literature bears that out. Yeah, thanks for sharing. Okay. So for me, when I think about the developmental impacts of prenatal substance exposure risk, I think about all of the things, as I said, that can impact a child's development. I can think about access to family support services, access to food and clothing and housing, whether or not the family has intergenerational wealth, um, whether or not children are getting early education and therapeutic support services, whether there's prenatal substance exposure, institutional or interpersonal racism. genetics of the child themselves and other health conditions, and then the biological parent's health history and genetic history, right? So if we have a family history of gestational parent or biological parents with learning disabilities and ADHD or intellectual disability, and then so there's this sort of genetic fragility associated with just the underlying biology of the gestational and biological parents. And then you add on top of that other exposures like prenatal trauma, prenatal substance exposure, chronic stress, all of those things, all of that comes together to impact the child's development. And so it's really complicated. And there have been some really interesting studies looking at prenatal alcohol exposure in twins. And so if we think about twins, they're in the same uterus with the same alcohol exposure, and one of the twins will have all of the classic signs and symptoms of fetal alcohol spectrum disorder, and the other won't. And we won't know why. I think it's because we don't really understand how a child's genetics and biology interact with environmental influences perfectly. We can't predict these things. And so I think it's just important to bear in mind that while children remain at increased risk, it's not a foregone conclusion. So lastly, we'll talk, and probably many of you already know and have taken advantage of all of these, of the resources that I'm going to talk about next. The key support resources recommended for patients born with high-risk experiences, and that includes prenatal drug exposure. Here's my quiz to keep you on your toes. So it'd be interesting to hear, I don't know if I'm allowed to ask this, but which supports have you accessed in the past? With not necessarily your current children, but past, like which ones do you know of and which ones have you intersected with? Sorry, let me go back here. Scrolling down, we've got lots of folks who've taken advantage of Head Start and Birth to 3 and developmental preschool and PCIT, behavior therapy with parent training, special education, developmental monitoring, infant mental health, and the Washington State Mental Health Referral Line haven't been picked yet. Seems like some folks know a lot about these things. My favorite resources are listed. Let's see how many pages of favorite resources. I have several pages of favorite resources. My favorite of all favorites for little kids is Early Support for Infants and Toddlers, ESIT. It is available in every county. It is, and there are links to all of these things. So I wonder if I probably can just send this all to you with the links for this so that you can take a look at them. But I think that Within Reach is a great program that offers general support and a resource connector for families within Washington State. And within Reach is the Parent Help 123 resource finder, which I think is super cool. I kind of want to show it to you right now. So I think I'm going to do that. Has anybody, let me see if I can see people's faces. Has anybody used the Parent Help 123 resource finder through Within Reach? Oh man, I really like it. Okay, I'm gonna show it to you really quick because I got really excited when I found it. Let me stop my sharing for a sec and then reshare. make you all small. So this is a really cool website that anyone can access where you can put in your city, state, and search for a resource. So I need these things, like I need help with parenting, for example, and then you can put, Yakima, Washington. And then it'll start spitting out all sorts of different kinds of resources in and around Yakima, the Yakima area. They'll prioritize those, which I think is really awesome. If you don't know where to start, I think probably many of you already do, but if you don't know where to start, parent or the Parent Help 123 resource finder, you can search for almost anything. And then they have a whole bunch of other information here. And that's all, I think, really pretty awesome. Okay, now I'm going to stop sharing, go back to the PowerPoint. Where's the PowerPoint? Here it is. Okay. So all of these have links, so I can certainly pull some of these slides out that have links so that you can see them, because I don't know if you can do it with a PDF. I'll check, but regardless, I'll save it so that you all can have access to these resources if you're interested in looking at them. We have many of you had already reported that they've taken advantage of special education and Head Start. The Washington State Pediatric Mental Health Referral Line is through the psychiatric department at Seattle Children's. And if you are looking for a specific type of mental health support, and providers will say contact your insurance and find the providers in your area. And when you're using state health insurance, it's sometimes really hard to access providers that are in your area that have the ability to see you. Wait, oh, I lost that. There we go. And so what you can do if you're lost, which I have used the pediatric mental health referral line myself, so I can sing its praises, is you can call them, or you can fill out a form for asking for what kind of mental health support do you need for your child. You give them your health insurance, and over the course of a couple of weeks to a month, they'll search your health insurance and search for providers that do the thing that you're looking for, and will work with you to find a provider that can see you. I think it's super, super neat. And so for anyone in Washington State, for any child in Washington State, so if you're at a loss and you've done your Google searching and you've tried, the Washington State Pediatric Mental Health Referral Line is really where you can go. It takes a little time. It takes like a month to get it from when you call or fill out the online form to when you have a list, but you can figure it out, and they provide support for you. So I think that's really neat. I have found for my patients and my clients that sometimes wrap around with intensive services or WISE, depending on the county within which you reside, have been particularly helpful. Seattle Children's now has an urgent care clinic. So for non-urgent psychiatric concerns, the urgent care clinic is available if you live around here or if you can travel to main campus. And then also, I think it's important that families and caregivers understand how to get special education supports for behavior challenges in school. So requesting a functional behavioral assessment, and also then getting a behavior intervention plan. So I don't know if any of you have had the experience where you've had your child be expelled from school for behavior. Nothing makes me more frustrated when children get expelled for challenging behaviors, because for whatever reason that the child is having these behaviors, their behavior is impacting their ability to participate in school, and therefore it is the school's responsibility to address that behavior in a classroom setting and to support that child. So whether it's a developmental or psychological issue and they're in public school, it's the school's responsibility to help work with that family to help that child participate in school. And so knowing that you can request functional behavioral assessments through the Office of Special Education and Instruction and behavior intervention plans is an important tool to have in your toolkit if you are feeling like the school is suspending and expelling your child. Okay, so here's what I've yammered at you for the last 40 minutes about. I talked to you a little bit about our developmental monitoring program for kids with complicated early prenatal and neonatal experiences. It's over at the University of Washington behind the UW Medical Center in Montlake. I've talked to you about what I feel like we know and what we don't know about developmental outcomes of children born prenatally exposed to a few different substances. I definitely have a personal feeling about the complexity of prenatal substance exposure and how really we have to think more broadly about who is this little person in front of us and what are they experiencing, and how whatever it was they were experiencing is impacting who they are in this moment. And it's not just one thing. And then I have a long list of key support resources that I recommend to patients, and some I've even used for myself to support my own family, who, everybody develops a little differently. So, yeah, I think that's what we talked about today. So I'm going to stop sharing and